which when it contracts, it becomes disconnected. We think that the muscle is dead, and there's no point revascularizing. But when we see hypokinesis, we think about the polar bear. Now, the polar bear can be lying down like it's dead, but it's probably sleeping, right? So that is how the heart muscle behaves. Now, if you prevent the heart muscle from getting a lot of blood, what it will do is, oh, I'm not getting enough blood, so we stay without moving. So it will be doing what we call hibernating. And if you're able to restore blood flow to it, it will start moving again. Now, this is what we look for in viability studies. Is the heart muscle alive but hibernating, or is it dead? Now, the modalities we use are dovitamin stress echo, cardiac MRI. We use gadolinium, so the images I showed you will end that study by giving the individual gadolinium, and I'll show you some pictures of how they show up, and then we can use PET to do that. Now, with echo, what we do is a series of increments in dovitamin infusion. We start from 5, 10, 15, and then we end at 20. What we're looking for is what we call a biphasic response, where you look at the heart muscle is not moving, you increase it to 10, the heart muscle starts moving, then you move it to 15, it outstretches blood supply, and then it stops moving. Then you know, oh, this is a viable muscle, this person will benefit from undergoing a cardiac catheterization and revascularization. Now, if it stays flat throughout the dovitamin infusion, that muscle is not viable, so you don't need to revascularize. Now, for PET, what is done here is you tag a glucose with a nuclear material, with your nuclear material. Now, what you do is you inject it in the individual. Muscles that are alive will try and take up glucose to metabolize. So if that muscle is alive, will take up that glucose. Once it takes up the glucose, the radioactive material is there. If you use your gamma camera to look at it, you will see that it lights up, and you know these muscles are viable. MRI, though, is different. Now, once you're ending the study, you give them a contrast agent called gadolinium. Now, gadolinium tends to hold up to fibrous tissue. So if you have a fibrous tissue in the muscle, the gadolinium will hold on to it. Now, I have a picture here of a viability study, one shot of it, and you can see that this is a 4-chamber view. You have the right ventricle, the left ventricle, the right atrium, the left atrium. You could see here that even though these individuals have gotten gadolinium, this whole muscle is good, right? It's all dark, there's no white stuff. The muscle did not hold on to gadolinium. So if this were a patient with poor ejection fraction, and I'm deciding on whether or not I need to send this patient for revascularizing, this is a yes. Now compare that to this individual here, who will also have the wall not moving, but the wall is dead. You see how the lateral wall has taken up gadolinium, and then it's all dead. So if you get this scenario, then you know that you probably should not be proceeding to cardiac catheterization and revascularization. Now, in all these cases, once you pick up the person needs to be revascularized or not, then you determine the appropriate mode of revascularization. Now, most of the time, if it is due to a reduced ejection fraction, the optimum one tends to be bypass, because most individuals with that amount of reduced function either has left main lesions or 3-vessel disease, or a diabetic with 2-vessel disease, all of which are indications for them to go to the cardiac catheterization lab. So I hope I've been able to talk within these 20 minutes that the underlying pathology of coronary artery is atherosclerosis. You have multiple pathophysiologies. Now, we used to think 30 years ago that it's all one pathophysiology, the vessel gets narrow, and it occludes. No. Part of it is that way. But another part of it is that is how come me and you sitting here can have a heart attack right now. We probably have a 20% lesion sitting somewhere, and these 20% lesions can rupture, and we can go on to have an acute MI right in front of us right now. The clinical presentation dictates the treatment. I hope I've shown you that. For STEMIs and NSTEMIs, it's revascularization, revascularization, revascularization. Now, we know from trials that STEMIs, stenting helps. And STEMIs, yes, not STEMIs. STEMIs, nobody would do a trial because the person is dying, right? So we assume what we're doing helps them, okay? But the general message that I'll leave with all the fellows here, that in general with coronary artery disease, stenting is for relieving symptoms. These are medications that prolongs life. So if your patients cannot get stenting, but they can take medications, they will live to be as long as they were meant to live on this planet. I would like to thank all the CTU staff for this presentation, especially Dr. Paul, and for my mate, my wife, who, without her, I wouldn't be sitting here doing anything, and the audience for listening. Thank you very much.